mentioned, my name is Aimee Cloutier. I'm a PhD student in mechanical engineering at Texas Tech University, studying with Dr. James Young in the Human-Centric Design Research Lab. The research that I'm presenting this morning is on identifying possible patient slips and falls using a series of motion capture experiments. So I'll just give a quick overview to begin. I'll start by talking about the motivation and some of the related literature to our project. Then I will talk about some of the methods we used, including the experimental setup and the data processing. And finally, I'll go over the results and give a discussion and some future work. So the prevention of slips and falls is becoming a very prominent area of research. And if you were here yesterday morning to hear the keynote speaker, you would have heard him mention addressing slips and falls as a priority for hospitals and for healthcare workers. So it's clear that it's definitely necessary to address this issue. For our study in particular, we chose specifically to focus on the older adult demographic, mainly just because it affects them more than it affects the rest of the population. So about 1 in 3 older adults over the age of 65 will experience a fall each year. And so of those, the ones that experience moderate to severe falls may experience a bone fracture, a hip injury, some sort of head trauma. And these injuries can lead to hospitalization and a loss of independence for the older adults. In addition to that, the fear of falling, even if an older adult doesn't fall, the fear of falling can also lead to a loss of independence. And so in addition to the strain that it puts on the older adults themselves, it also puts a strain on the financial systems of the hospitals. And so I think in 2012, the direct medical cost related to treating falls was measured at about $30 billion, and that number is expected to continue growing. And so for hospitals, the most compelling piece of evidence that I saw is that the Centers for Medicare and Medicaid in 2008 created a ruling that said that they basically would not provide funding anymore to treat, for hospitals to treat injuries based on falls that occurred within the hospitals. And they did that basically as an incentive for these hospitals to actually start addressing the issue of falls and how to prevent them. So for our present study, we are collaborating with the Department of Design at our university. And so we're mainly focusing on the locations and the movements that might trigger potential falls, basically so that we can identify maybe some better furniture designs or better layout designs that might lead to a safer environment for the patients and for the healthcare workers. So we used a motion capture experiment in order to do this. We tested both bedroom and bathroom settings within our own lab, and so we created some mock-ups in order to do that. And we had a subject set of 30 subjects over the age of 70, and our metric for determining when a potential fall was occurring was the jerk trajectory of the center of mass. So some of the previous literature related to identifying falls has shown that falls do not remain consistent across patient groups and across environments. So for example, falls are more likely to occur in hospitals than they are in communities. And in addition to that, within hospitals, older adults are more likely to fall than other patients. In addition to that, there are patient-specific and environment-specific factors that change the frequency and the location of falls. And an example of that is that patients who are classified as frail will tend to fall more in the bathroom, whereas patients who are classified as confused tend to fall more by the bed. And so these patient-specific and environment-specific factors can be termed intrinsic and extrinsic factors. And so some of the extrinsic or environmental factors that can be studied would be the height of the bed, the positioning of the bed rails, the floor conditions, the lighting conditions, the layout of the room, and the furniture design. And some of the intrinsic or patient-specific factors that can be addressed might include age, like we've done here, in addition to the use of medication or confusion of the patient, hearing and vision disabilities, and among other things. So a lot of the previous studies on patient slips and falls have drawn data from repositories of reports that were filed by healthcare workers on these falls. And so doing the analyses that way basically limits the analysis to the location of the fall, and some of the intrinsic factors may be related to the physical and mental state of the patient. By contrast to that, using experimental methods instead would allow us to test some of the more precise factors that might be leading to falls. And so there are several researchers that I've listed here who've done that. So this first group, led by Dr. Young, not the same one that I work with, is basically testing which stability factors, like the step width and things like that, can be used to accurately predict falls in older adults. So for our specific study, we used an 8-Eagle-4 motion capture system for motion analysis. I have the marker placement that we used shown here. We had about 60 markers used on the body. And as I mentioned already, we had 30 subjects over the age of 70, 15 male and 15 female that we recruited to participate in the experiment. Each subject wore a protective harness throughout the course of the experiment so that in case a fall did occur, it would help to prevent injury. Okay, and so as I mentioned previously, we created some mock-ups within our own lab to perform these experiments. And so right here I have shown the bathroom setup that we used. The first 10 subjects participated in one bathroom setup, for which the bathroom was located to the left of the bed. And then the next 20 subjects participated in the setup where the bathroom was to the right of the bed. So when we were designing these layouts, we went to one of the local hospitals and we took the dimensions and layout for the bedroom and bathroom setups from the rooms that they actually have in those hospitals. Then we did the actual setups in our lab. We ran a test experiment before bringing any subjects in, and we invited a series of healthcare workers to come in and watch that experiment to ensure that we would be representing an accurate situation. And so one of the goals of this experiment was to have the subjects go through a very natural progression of tasks rather than isolating some of the movements that might be occurring. So some of the variables that we were looking at here, first of all, would be the location of the IV, whether it was on the left hand or on the right hand. And the other variable we looked at was the door condition. So we had two separate locations for the door number 1 and door number 2, both of which open inside. And then door number 3, which is located in the same place as door number 2, but which opens to the outside. So with 2 IV positions and 3 door conditions, that leads to a total of 6 different scenarios that the subject is performing. We repeated each scenario 3 times, and so the subject would perform a total of 18 different trials. And so I'm just going to show the progression of the bathroom tasks that each subject was asked to do. We had one lab member sitting with a script and reading out all the instructions for the subject to go through. So the subject was first instructed to stand up and to walk through either one of doors number 1, 2, or 3. Then to walk to the toilet and lower the toilet seat. To sit down and use the toilet or pretend to use the toilet. Then to stand up, lift the toilet seat, and walk over to the sink and wash his or her hands. And then after that, the subject was just instructed to leave through the same door in which they entered. And then the progression of tasks is essentially the same for doors 2 and 3. And so here we just have an example of one of the subjects performing a bathroom task, and we have the script reader you can see right behind her. So then our final 10 subjects performed the bedroom series of tasks. The first variable of interest for the bedroom setup again was whether the IV was on the left or the right hand. And if the IV was on the left hand, the furniture was located to the left of the bed. And if the IV was on the right hand, the furniture would be located to the right. Then in addition to that, we had 4 different door conditions, 2 where the doors were located on the left, and 2 where the doors were located on the right. In this case, the third door condition was eliminated because the subjects weren't actually going into the bathroom at this point. They were just walking to that location. So that created a total of 8 different scenarios for each subject to perform. Each one was repeated 3 times again, which led to 24 separate trials that each subject would perform. Okay, so for the bedroom task, the subject was first asked to stand up and walk over to a chair that was located near the bed, to sit down, and then stand up and walk to one of the 4 different doors. Then after that, the subject would return to the chair, sit down again, stand up, walk to the bed, and reach for a glass on the bedside table to take a drink, then put the glass back down. And so here is just an example of generally the bedroom setup that we had. with the bedside table located near it. Because of problems that we expected to have with marker occlusion, we could not use one of the regular chairs that they might use in that environment. We had to use a backless chair so that the markers in the back would not be obscured. We also had a trash can just to provide a little bit of an extra obstacle that they might have to maneuver around in an actual hospital setting. And here's the bedroom setup with the bathroom mock-up next to it in another angle. So the ultimate goal of the data processing was to locate the trajectory of the center of mass of the body throughout the course of every trial. And so the first step to do that was just to label the markers using Cortex, which is part of motion analysis, and then to transfer those marker labels into Visual3D to locate the center of mass throughout the course of every trial. So from there, we could use MATLAB to calculate the jerk trajectory of the center of mass throughout the entire trial. And so jerk is a parameter of interest for falls applications because it is generally thought for human movement to correspond to the smoothness of the movement. So there are several researchers who in the past have used jerk as a metric either for the detection of falls and automatic fall detection, or for the identification of maybe the differences between simulated and real-world falls. So the first reference that I have here, they created an automatic fall detection system where the maximum jerk threshold was sort of the threshold between a fall and a recovery, I suppose. And so that would trigger an alarm for a nurse to come in so that they could help with the patient. And then the next resource here was identifying the differences between the simulated and real-world falls. And they were able to show that the maximum jerk that occurs in real-world falls is significantly higher than the jerk that occurs with the simulated falls. So the success of studies like these points toward jerk as a useful parameter in the identification of potential falls. And so the figure that I have up here is just one example of the jerk trajectory throughout a trial for one of our subjects. And so we're looking for areas where the jerk is higher, because that would correspond to less stable movement. And so you can probably observe two different types of higher jerk behavior. The first would be these larger spikes in the data, which we attributed to noise due to the virtual data that we had to fill in for some of the marker occlusion. And so when we looked back at the motion capture data, we were able to verify that these larger spikes are due to noise. And so then the higher jerk data that we would be dealing with for the identification of potential falls would be these smaller but more consistent hills in the jerk trajectory. So at this point, that's a very qualitative assessment of how we can identify a fall versus an area where the patient is generally safe. So here we took some steps basically to quantify a little bit more what counts as a potential fall and what does not. And I should mention here that throughout our experiment, we didn't try to induce falls in any way, and we did not actually have any subjects who fell throughout the course of the experiments. So when we're identifying potential falls, we're sort of relying on this information that I've already given you and the previous literature to sort of figure out when the potential falls would be occurring. So I have the equation here used to calculate the jerk in MATLAB. And then we wanted to do a little bit to sort of filter out some of that noise that we were seeing. So we expected that noise to occur as outliers in the data. And so we used a common method in statistics for calculating the outliers based on the interquartile range. And that calculation is based on the median of the data rather than the mean, because the median is far less sensitive to outliers than the mean is. So we were able to identify, using this method, the median of the data and the data points that would count as minor outliers and those that would count as major outliers. So I'm going to bring back up that same jerk trajectory that I showed before, but pointing out some of the areas that might be considered outliers. So hopefully you can see this blue line down here at the bottom. That's actually the median of the data. And so a little bit above that, this lower dotted red line that we have here, that's the threshold for minor outliers. So anything above that point would be considered a minor outlier. And then this upper red line that we have right here represents the threshold for major outliers, and anything above it would qualify as a major outlier. And so based on sort of a fine-tuning process where we were looking at these different fall ranges in the motion capture and trying to identify them in MATLAB, we came up with a set of criteria that for our data set would identify a potential fall. So the first is that 70% of the data points need to lie above the median. The second is that no more than 15% may qualify as minor outliers. And the third is that no more than 10% of the data points may qualify as major outliers. And so these green dotted lines that I have right here represent the start and end points that we identified for one of several potential falls in this trial. So we took some steps to quantify this, but it's still fairly qualitative. And so as an additional measure, we would look at each one of these identified regions in the motion capture software to determine whether the fall might actually have been due to instability, or if it was due to, or if we were seeing a potential fall maybe due to noise or some external factors like difficulty maneuvering with the harness that might have been unrelated to the experiment. So the results that we found, we identified 230 potential falls in the first bathroom setup, 210 in the second bathroom setup, and 300 in the bedroom setup. And that averages out to roughly 4 potential falls for a trial that might be maybe about 3 minutes long. And so one area that was identified as a trigger of potential falls in the bathroom was the use of sideways or backward steps. And so the occurrence of these types of motions was generally subject specific. So not all subjects would choose to maneuver throughout the bathroom that way, but those who did generally had these areas show up as potential falls a lot more than the others. And so the areas of the room that would generally occur in would be near the door. So when they're trying to back out of the bathroom, they would have maybe the IV in one hand and they'd be holding the door handle and they would try to back out of the bathroom that way. And that was identified as a condition that might create some instability. In the bedroom, we identified lots of potential falls for sitting and standing tasks. And we attribute this partially to the fact that the subject was asked to sit and stand, I think, about 6 times throughout every trial. So we had a lot of cases where the subject was asked to sit and stand. Reaching was identified as a trigger for falls in all 3 of the scenarios. And reaching generally occurred in the bedroom when the subject was trying to maybe reach for a glass of water on the table. And reaching in the bathroom usually occurred when they were trying to lower or lift the toilet seat, or when they were entering or leaving the bathroom to grab the door handle. But the one that was of most interest to us was turning. So turning came up in every single setup, and the numbers are fairly high for the amount of potential falls that we identified due to turning. And so we did a little bit more digging to figure out why turning might be causing so many of these potential falls. One of the reasons in the bathroom, first of all, might be because of the frequency that the subject feels the need to turn. So when they're turning to lower the toilet seat and then to use the toilet, turns to get to the sink, turns to get out, there are a lot of them in the bathroom setting. And so there's another study that was done a couple of years ago that was trying to identify whether turning does increase the risk of falls compared to straight walking. And so they found that with a turning angle of about 60 degrees as opposed to straight walking, which is the highest angle that they studied, the risk of falling increased by about 42%. So that's definitely significant. And so some of the factors that can be identified as reasons for that would be that there is a higher required coefficient of friction between the shoe and the floor during turning, and also that slips during turning cause the base of support to move in the opposite direction as the center of mass, which creates more instability. Okay, so we were able to identify falls that occurred during turning, reaching, taking backwards and sideways steps, and sitting and standing. There are several potential sources of error in this study. One of them that I already mentioned is that nobody fell throughout the course of experiments. So we were having to do definitely a little bit of guesswork, I suppose, to determine when those potential falls were occurring. Another major source of error, I think, may have been due to marker occlusion. So we only had an 8-camera setup, and we had these, wooden mock-ups in the room. We had a large bed, and so marker occlusion did become an issue that we had to address, particularly on the lower half of the body. Another issue may have been due to atypical behavior of the subjects due to the experimental setup. So possibly discomfort or discomfort moving with the harness, and also maybe a little bit of discomfort being asked to perform some of the tasks, with researchers and cameras on them. And the final potential source of error that we identified is that in terms of intrinsic and extrinsic factors, we only considered age and sort of the layout of the room. But in a realistic hospital situation, there would be many, many intrinsic and extrinsic factors that would change maybe the location and the frequency of the falls. So it would be useful maybe to consider some more of those intrinsic and extrinsic factors in future studies. Okay, and so I would hesitate to talk too much about improvements to the bedroom and bathroom layout because that is currently being addressed by the design department that we are collaborating with. But one fairly obvious observation might be that reducing the number of turns required in a bedroom and bathroom layout should reduce the number of falls. And so if we look back at the bedroom and bathroom layout that we had for one of our bathrooms, there are no turns required to get from the bed to door number 1, whereas you might have to do 3 or 4 to get to door numbers 2 or 3. So a layout that uses door number 1 could potentially reduce the number of falls as compared to one that uses doors 2 or 3. So during the experiment, we also recorded the data with 2 video cameras from 2 different angles, and we identified each potential fall in those video recordings as well. Sent it to our collaborators and a team of healthcare professionals who are analyzing it currently to see if they can spot maybe some of the dangers that we identified. And so after that step, we will work with the design department to maybe try and identify some factors that could improve the design of the furniture or to the layout of the bedroom. Once we have identified those factors, it would be useful for us to run another set of experiments to see how those changes affected it. In addition to that, I believe at the moment we're working on upgrading our camera system to have a lot more cameras, and so hopefully with the next run of experiments we won't have the same issues with marker occlusion that we ran into this time. And a final area of study that might be of interest is to isolate some of those movements that we identified as triggers for potential falls and maybe compare them to some of the traditional methods for assessing falls, like the center of mass with respect to the stability region of the feet, and to determine if those movements in particular are identified as potential falls, both with the jerk metric and with others as well. All right, thank you for your attention. What questions do you have? Yeah.
I'm not very well versed in the world of motion capture.
Mm-hmm.
Is it possible to use a solid-state accelerometer-based setup to capture some of this motion, perhaps inside of the actual hospital rooms?
Mm-hmm. Yeah, we did consider that. One of the reasons for using the optical motion capture system that we used is that it's highly accurate, definitely more so with compared to the accelerometers. And second of all, with tracking the center of mass like we did, the optical motion capture system definitely does that a lot better than an accelerometer would do. But we definitely did consider some of those options for the study. Yeah.
Along the same line,
Mm-hmm.
did you consider any pressure sensors in their shoes to see the contact with the floor? So slip typically is characterized by this kind of motion.
Mm-hmm.
So that's something you might be able to capture by having sensors in there.
Yeah. So I think actually with our next round of experiments, one thing I didn't mention is that we're also planning to incorporate force plates into our lab, and so we should be able to maybe address some of the things that you're talking about in the next round. Yeah.
I just had 2 brief questions. One, have you guys ever looked at a bedside commode rather than looking at a bathroom? Because it may seem like it's safer, but actually a lot of my patients fell when I was on inpatient services trying to actually just get up in bed and use a bedside commode.
Mm-hmm.
But again, my patients were probably a little bit more debilitated than some others of my homeless stroke patients. But in addition to that, the other thing that led to a lot of my patients falling were SCD, spontaneous compression devices to prevent deep vein thrombosis.
Mm-hmm.
And it's actually a glove that goes over the lower leg, spontaneously compresses. And so I'm wondering if you guys are going to look at that at all either, because I would be really interested to see if you guys had any recommendations for changing the mechanics of it or anything like that.
So in terms of the bedside commode, we did not consider that. It's a good point, and I'm not sure if we're going to consider that maybe in our next run of the experiments. In terms of the other thing you mentioned, probably not something that we're going to consider in the near future, but it's definitely an interesting topic that I can bring up and that we might be able to pursue later. I think you had a question.
I wanted to say great job on that study. You did a great job. One thing that might help with the marker inclusion is if you put segments, or if you put clusters on the segments, like if you put like 4 markers on the thigh, if you have occlusion of one of them, the program would be able to continue tracking the segment regardless of one of them being missing.
Yeah, so one of the reasons we had such a large marker set, I'm not sure if you're familiar with the usual number of markers that would be used, but ours was like 60 or 62 markers. It's a lot more than you would usually use. And one of the reasons for that was actually to address the problem of marker occlusion that we were having. But that's also a great suggestion, so thanks for that. Yeah.
I understand why you guys recruited older age adults, but have you considered recruiting some younger age people as well, just to understand the fundamental differences in how whether your risk for falling or returning actually differs among the ages?
Yeah, so I think at the present stage we're just going to be focusing on the elderly population, but I think it actually is a really interesting direction future work to see if the motions that we've identified as triggers for the older patients might be the same for the younger ones as well. Yeah.
This may sound crazy, but for high risk, high consequence, I'm sure there's some patients a fall could be just devastating. And the structure that there looks like it could prevent a car from falling. I'm wondering if there's any consideration about a simple harness system for patients that are at high risk, where they could actually connect in like a cable or a zip line, and they could walk around the room, and if they did fall, they would be held up by the harness itself.
Well, I know that this looks daunting, but in actual practice, we did have the cable that was strapped to the back of the harness, and they were able to move very smoothly about the room. We did have issues in 1 or 2 locations where the harness would catch, but in general, I'm not sure that they were having a lot of problems maneuvering with the harness. It seemed to be pretty smooth movement.
They may say, I'm fine with wearing a harness because if I fall, that might just be it for me. So go ahead and strap me in. I would love to have that label instead of taking the risk.
Yeah. Do you have time?
We'll have time for one more.
Okay.
I'm just curious if you considered any other variables, like that was talking about with the floor friction, the center of pressure of the insoles. I mean, because you're using Jerrod, you're inherently going to find that the riskiest motions are the times when they're turning, and I mean that's when there's acceleration stresses. So, did you consider any other variables to look at?
No, not at this stage. So I forgot to mention, this is a little bit of a pilot study for us. We're going to be doing a lot more work on this, and in the future I do expect that we will consider a lot more of those variables that you mentioned and that he mentioned as well. Yeah.
Good questions, and I'm sure Amy's happy to answer questions at lunch.
Yeah.